Welcome to Talkin Maine with the Bowtie Boy. I'm Tom Saviello. Today we're going to talk about strokes. But before we do, we have a special guest who's the expert on that. But she has a great background, and you are?
I'm Dr. Jodi Conrad. I'm the Medical Director of Emergency Services at Franklin Memorial Hospital.
Welcome.
Thanks for having me on your show.
Great to have you on the show. So Jodi, before we get into telestroke and how you're helping with that, tell us a little bit about your background, because I found it fascinating when we came in the door. And Ryan said I should ask.
So I am originally from West Virginia. I went to medical school without a bachelor's degree or a master's degree. I've done my prerequisites at a community college. We called Harvard by the Highway in Summersville, West Virginia. New River Community and Technical College was the name of it. And I went to med school, done my training in Hattiesburg, Mississippi. But before med school, I got a diverse background in primarily coal mining. I spent a large portion of my life in the coal field on surface mining. I've actually run the largest production equipment dozer that is made, as well as the second largest that is produced. But yeah, also have some background in law enforcement, EMS, and corrections.
Wow. See, the biggest I've been around, I think, is a D10 or D11 or something like that. How big was this guy?
So a D11T, and I've also ran a Komatsu 575, which is the largest bulldozer commercially produced in the U.S.
I mean, I've seen the coal mining trucks come out, the tires as big as this room,
yeah,
and they're filled up. So I can't imagine having something to push the coal around. So what made you decide to go into the medical field?
Well, I was kind of a wayward child, shall we say. When I graduated high school, I went to college initially, and I done really well my first semester, and then I learned how to party because I was a farm kid that grew up on the farm, and ended up leaving college to go to work and make some money. I married my wife along the way, who went to nursing school. Once she got through nursing school, we were at the beach with some family, and she said to me one day, she said, "When we get back home, why don't you just quit and go back to school?" So I quit and went back to school at New River Community College. And one of the professors there, Dr. Carol Friend, she used to teach microbiology at the med school. And after my first semester with her, she was very impressed with me for whatever reason. And she said, "Why don't you apply to medical school?" I said, "I'm a dumb coal miner, Carol." I said, "I'll never get into medical school." She said, "Well, just do me a favor. Take your MCAT and apply." So I did. And here I am today.
So where did you end up going to med school?
West Virginia School of Osteopathic Medicine.
Wow. And is that a 4-year program?
It is a 4-year. All med schools are 4-year programs.
Wow, I'm impressed.
I've done my residency training in Hattiesburg, Mississippi, Merit Health Wesley, in a 4-year emergency medicine residency program. There's still some of those around. Primarily emergency medicine residencies are 3 years, but I've done an extra year of training.
Wow. So what brought you to Franklin Memorial College? No, Franklin Memorial.
So Maine had always kind of been a dream as a child. You know, you dream of that far off place that you fantasize and romanticize, and Maine was kind of always that place for me. I rotated through Kent Hospital in Warwick, Rhode Island while I was in medical school, and while I was there, I had the opportunity to come up and visit Maine, and it was everything that I hoped that it would be. And so I actually had a contract at another hospital that was better paying, but a job come open in Maine, and I called and talked about the job, and they put me on the phone with Ryan Knapp, who was the director at the emergency department at the time, and spoke with Ryan and really enjoyed the conversation with him. So they brought me up for an interview, and it was everything that I hoped it would be.
Now, were you in the emergency room for a while and then became the director, or did you go right into the director's position?
No, so Abby was the director. You interviewed Abby before, shortly after he took over the director's job. But I was in the emergency room for 2 years, and then took over the director's position. Abby kind of just handed it over.
Good luck.
Good luck. I think that, he was getting a bit beat up. COVID's been hard on everybody. Yeah. We've had a lot of attrition from the medical field, and it's been rough on physicians. And emergency medicine's not what it used to be. But I took it over from him, but he's still the assistant director, and we work really well together. So
tell me, I know we're supposed to talk about telestroke, but you intrigued me. What's changed in the medical profession as a result of COVID and everything else?
So we're seeing higher volumes in the emergency department everywhere, not just here, but especially in rural communities, people left the cities. A lot of people could work remote. They could leave the cities. They could come to rural America, and they could work from home. And that hasn't really changed. Not a lot of places have went back to making people be in the office. So we've seen a lot of higher, a lot higher volumes. But aside from that, people seem generally sicker now. And I think that's due to an attrition of primary care physicians from the workforce and other specialty physicians from the workforce. People aren't being managed like they were before.
Yeah, I can understand that, because when you have a primary care physician, at least you have someone to call and check on. I mean,
Exactly.
I'm fortunate I have a great one, and I can email him and say, I stepped on a nail, my foot's turning red. I haven't done that in 70 years, and I did it in 70 years, and send him a picture, and he wrote in a prescription for me. But I was aware of what I had. Someone else might let it go and go and go, and then all of a sudden a real problem when it happens to theirs.
Exactly. They show up to the department septic, and then they're getting admitted to the hospital on IV antibiotics, where, if they had a primary care physician, they could have done just that, talked to him and got some antibiotics and kept from being in the hospital.
Yeah, and years ago, Jerry Tingley was my primary care physician. I don't know whether you met Jerry or not, but he's one of the originals that moved up here in the 70s as a doc, as a primary care physician. Anyway, he did some tests on me and thought, I think you need to have a colonoscopy. So I'm 42 years old. I go down and they find a huge polyp that had dysplasia in the end of it. And the Dr. O'Connor, who did my colonoscopy, basically said, it's a good thing you came here, because if you didn't, you might be doing a bowel resection and chemotherapy in a couple months. And so it's like I caught it early. That's one of the reasons why I supported Medicaid expansion, because if you catch it early, it's couple $1,000. If you catch it late, it's hundreds of thousands.
It's hundreds of thousands of dollars. Cancer treatment is highly expensive. That's why it's important to have a primary care physician and get all of your preventative health maintenance and screenings and work with them to develop a healthy lifestyle.
Yeah, I don't know if my lifestyle is healthy, but I get along. So tell me a little bit about the involvement with strokes. And we'll probably talk about the emergency room a little bit,
Okay.
But let's talk about strokes. Telestroke. What's that all about?
So telestroke, think of a really fancy Zoom call. The neurologist is sitting on one end of the telestroke, and the patient's sitting on the other end of it, with a nurse or a physician at the bedside to help the neurologist to be their hands at the patient's side. But the neurologist can control the camera on the telestroke cart. It's essentially a monitor on a cart with a camera on top of it. And the patient can see the neurologist, and the neurologist can see the patient, and the patient can control the camera, and they can have a full conversation. And like I said, the neurologist can do testing utilizing a nurse at bedside or a physician at bedside.
So, but the patient is in the hospital. Exactly.
Yes, with the patient in the hospital, typically presenting to the emergency department. But sometimes a patient may develop a stroke while in the hospital, while they're on the med-surg floor, and it can be utilized on the med-surg floor as well. So
let me talk a little bit this as an example. I'll use myself as an example.
Okay.
And this is and I ended up not going in the hospital, but I had what I guess is called a TIA. Mm-hmm. Where I had a mini stroke of something weird went on in my head, more weird than normal. And I was at a friend's office, and all of a sudden I knew who he was, but I couldn't say his name. It was like, Jodi, I know Jodi's here, but I couldn't say Jodi. It would never come out of my mouth, but I knew what it was. And his wife came into the room, and I knew her, and the same thing, I couldn't get her name from the back of my head. Literally felt like the back of my head to my mouth. And I thought, well, maybe I had a sugar problem. So suppose at that point I called the ambulance and they took me to the hospital. Might I be a candidate for this kind of procedure?
Absolutely, you would be a candidate for that type of procedure. That's one of the many signs of stroke. We would call that expressive aphasia. You can't form words. You know what you want to say, but you can't say them. So if the ambulance found you, they would utilize a stroke assessment tool that they use in the field called the FAST-ED. So the things that they look for are face, so facial droop or facial numbness or facial paralysis.
I had none of that. So we'll go through the checklist.
Okay, we'll go through the checklist here. Arms and legs, that's A, is arms and legs.
Numbness or?
Numbness or weakness, lateralized to one side of the body. A stroke will always present typically below the neck on one side of the body and above the neck on the other side of the body.
I had none of that. In fact, as I think I told you, I drove home. But the interesting thing, just to sidelight, again, using me as an example, I could talk. I could carry on a conversation. I just couldn't connect the names.
Okay.
So I had none of the weaknesses.
Then that would be receptive aphasia, actually. I misspoke, so you would have had receptive aphasia. So the other thing that they look for is speech difficulties, so slurred speech, inability to form words, or inability to recognize words or written or spoken. Time. So the very important thing, time is brain. When we talk about a stroke, time is brain cells. So they need to know a last known well time. That's the most important part of getting appropriate stroke treatment, is knowing the last known well time. Because to give the primary medication that we would give, which is fibrinolytic, TPA, think of it as Drano for your arteries. It breaks up the clog. To give that, we have to be within 4 hours of stroke onset, and there's a lot of other things that we have to check off the list that are contraindications. But given it beyond that, it's a really high-risk medication. And then eye deviation, so deviation of the eyes to one side of the body, and the severity of that, whether they can be brought back to the midline.
So let's go back to the well time for a minute.
Okay.
All right. So in that case, I mean, I can remember the day vividly. In fact, I tell people it was like an out-of-body experience, because I'm in this office and I'm watching myself, laughing at myself that I can't do this. So my well time would have been, if someone had asked me, I would have had no symptoms like this until I drove into that yard. So
right.
I'm able, a stroke victim able to articulate that? Are you looking at maybe his wife or her husband or someone to articulate that?
Right. So you're always looking for EMS or us, depending. You're always looking for somebody who can definitively define when the last time that they did not have these stroke symptoms was. If we don't know that, we can't give the medication, the clot buster medication. There's other things we can do, obviously, but the primary stroke treatment, the TPA, we can only give that if we have a last known well time. So it's extremely important to, if you're a family member of somebody that's had a stroke, to be able to articulate that. Now, some people wake up with stroke symptoms. If you wake up from sleep, your last known well time is going to be well outside of that window.
I had a friend who had a stroke down in Jay, and he literally fell out of the bed. So they didn't know when his well time was, and they couldn't do the treatment. And my understanding, this treatment is very significant because it can really make a difference between a severe stroke and a moderate to slight stroke. Is that correct?
Yes, that's correct.
So that well time is really essential. It's best if you're around somebody that has high blood pressure or might be susceptible to it in family history. That's a very important point to kind of remember.
Correct. There's also certain strokes that we can't treat with that, which is a more rare type of stroke. 85% of stroke victims are thromboembolic strokes. They're a clog in the artery. 13% to 15% of stroke victims are from a ruptured aneurysm with blood in the head, and the treatment for that is something completely different.
Yeah, that one's you got to operate on.
Yeah, correct. That one you're getting an operation for coiling and stenting and maybe a shunt, or yeah.
Oh, you're in deep doo-doo.
You're in deep doo-doo.
Yeah.
Those are low survivability strokes. Hemorrhagic strokes are typically low survivability.
I know 2 people actually survived them, so it's interesting.
They beat the odds.
Yeah, they beat the odds. Is huge. So keep going. All right. So I interrupted you. We go back.
No,
let's
you're
go back
fine.
from I could define my well care if we continued on and I had stroke symptoms. And then you talked about my eyes. My eyes were right where they needed to be.
Right.
I could see just fine.
And then D is denial or neglect, and this happens in severe strokes. I've seen a few people with this. They're unable to recognize one side of their body. They can't recognize anything that's going on, including their own limbs. They don't recognize their limbs as theirs. They don't recognize anything that's going on that side of their body, and it's called hemi-neglect. But in the fast ED, it's denial, just to make it.
So I'm literally looking at my hand and don't know that it's part of my body.
And don't know that it's part of your body.
Wow.
Yeah.
Wow, that's fascinating. So I didn't have that. I know that because I drove home. As I said, I drove home and I got into the house. So in my case, they put me through a set of tests. So what would you go through now? I've gone through this test, kind of didn't show anything. What would be the next series of things that you would do with me?
Well, so let's kind of back up and go back to when EMS finds a stroke patient or when a stroke patient arrives in our department. We use a little bit different score called the NIHSS, and I won't go into that. It's an extremely long stroke scaling score that determines the severity of a stroke. Typically less than 8, a score of less than 8 without debilitating symptoms, we're not going to give this clot busting medication because the clot busting medication is not without risks. But when a patient presents to the ED, if they present via EMS typically notifies us from the field and we have some time to get things ready. As soon as the patient rolls through the door, or if the patient walks into the emergency department and the nurse in triage recognizes that this patient has stroke symptoms, they notify us. When the ambulance rolls through the door, when we see the patient in the triage room and we verify that they have stroke symptoms, the first thing you're going to do is go to radiology. You're going to get a CT scan of your head to evaluate for bleeding, or the rare type of stroke, which is a ruptured aneurysm, intracranial hemorrhage. And then we'll do a CTA of the head, which looks for blockages in the arteries of the neck and head.
So what's CTA stand for?
CT angiography. Computed tomography angiography.
You're looking at my brain structure.
Looking at the vessels in your brain and your neck to evaluate for a blockage, because that's what causes a thromboembolic stroke, is a clog in the artery affecting a certain part of the brain.
So would that be where they would go to my whatever 2 arteries here, kind of check to make sure that the blood supply is okay coming through with whatever?
Yes, a carotid ultrasound evaluates your carotids to evaluate for blood flow coming through and look for vascular disease, which isn't uncommon, especially in our population with a high-fat, high-carbohydrate diet. So while you were in radiology having that CT scan, if EMS had gave me a last known well time, I know, are you a potential candidate for this medication? If you walked in through the door, if you were unable to give it to me yourself, I'm going to be trying to find somebody that can give me that time. And at the same time, I'm going to be putting in an order to consult the telestroke program. So that when you get back from radiology, that telestroke card is going to be sitting at the bedside, and the neurologist is going to be ready to evaluate you. I do my own independent evaluation. They do their own independent evaluation. And then once they've done their evaluation, they call me and we talk again. And, we're going to come to a conclusion. Is this patient a candidate? Are they appropriate for the medication? Do they need to go to Maine Med for something different, for interventional? Are they outside of the window completely? And do they need to go to the med-surg floor and have further workup? When you come in, you're going to get a CT, you're going to get blood work, you're going to get an EKG, and you're going to get a good, thorough physical history and physical exam. But then once we make that determination, you're either going to stay in the hospital and get conservative management if you're outside of the window for TPA, or the window for interventional is a little bit longer, where they actually go in and pull the clot out. That window is a little bit longer. But if you're outside the window for either of those, you're going to come in the hospital. You're going to get what's called antiplatelet agents, which just prevents platelet aggregation. You're going to get an ultrasound of your heart and your arteries, and you're probably going to get an MRI of your brain and the arteries in your brain.
Wow. I do know this. I did the CAT scan, and they came back and said, yes, you do have a brain. So a lot of people a lot of people thought that wasn't true. And then, as I said, I believe they did the scan on my carotids just to make sure there wasn't something going on there, and they were fine. And then by that time, I started rattling off to everything that's there. The only thing I felt bad for the doc was that I was getting back on my phone faster the results of the tests than he was able to come in and tell me.
It happens to us all the time.
And I'm sitting there, he comes in and I says, well, that MRI they just did, or the CAT scan, it's okay. It just says so right here. Oh, thanks. He hadn't even looked at the records yet. So, I mean, this showed that I had, whatever was going on with me, it had passed by.
So what we would typically call that is a TIA, or a transient ischemic attack. You had a micro blockage that resolved itself, and it went away on its own. And that's stroke symptoms that resolve within 24 hours. Is what we call a transient ischemic attack.
It was, as I said, but there was, on something like that, would you still find some kind of damage? Or
not necessarily. Not necessarily. If it was self-alleviating fast enough, there's not going to be any permanent damage. Like I said, time is brain. The longer that blockage sits there, the more damage is done to your brain.
Wow. It was a weird day. I mean, it was a very weird day. As I said, by the time I got within an hour of getting to the doc, to the hospital, I was sitting rattling off all these things I was supposed to do, and actually talking about the fact that when I was sitting in the chair, I was watching myself laughing my butt off, that I couldn't communicate with anybody, because anybody who knows me, I have a big mouth and I communicate pretty well, whether you like it or not. And it was like, whoa, this is weird. But that North Star, they have the ability to do some of this as they're coming to see you. I mean, North Star guys are great. I mean, I know
they are. They're phenomenal.
They're phenomenal.
We've got a great EMS service, and yeah, so that fast ED score that we talked about, they use it in the field to do a rapid evaluation for signs of stroke. Now, I've had some that they brought to me that I said, no, this isn't a stroke for whatever reason. There's other things that can mimic strokes. Or yeah, this certainly looks like a stroke. Do you have a last known well time? And hopefully they've always got that for me because it's part of their scoring. But the big thing is them notifying us before they get there that they have a potential stroke patient, so we can make room just to care for that patient.
Yeah, because time is, again, as you said, is critical in
Yeah.
this whole thing. Wow, it's phenomenal. I mean, my head grandmother died of a stroke because she had it, fell down the stairs, and that was the end. But she was 80
I'm
years
sorry
old.
to hear about that, by the way.
She was 80 years old. She had a great life. So at the end of the day, it was sad, but she had a great life.
She had a
That's the
great
way I
life.
look at it. And as I always describe to people, you have a certain date you start. That's the day you're born. And then you have the certain date that you die that you don't know. It's how you live the dash that makes the difference.
That's exactly right.
And so in her case, she lived the dash great. And
We can all only hope to aspire to live a great life.
that's correct, or have fun. So at the end of the day, I said, as I describe people that I speak at their funerals, is that they come stumbling and bumbling and bend down to the bottom of the thing, and they look up and they look at St. Peter and they say, boy, that was a hell of a ride. And it's been a good show.
I like that analogy.
It's so. Let's just talk a little bit about the emergency room. You know,
Okay.
one of the biggest complaints is I go there and I have to wait and wait and wait and wait. So explain why that happens.
So,
I mean, I'll share this with you. My last time in the emergency room, which was probably a little over a year ago, the nurse was great. She came out and communicated with us, told us that there was a patient in the back. So we weren't sitting in, and I don't know whether that was typical, and I assume it probably is, just to keep the patient informed. We got you, we understand, we haven't forgotten you. But answer that question, because that is the famous one that we get every time about the emergency room.
So again, our volumes are much higher than they've ever been. We're looking at seeing 18,000 patients through our emergency department this year.
Wow.
Which is huge.
That's huge.
Yeah, we've got 34 hours of physician coverage in our department right now. So typically, first thing in the morning, there's only one physician. After 8 p.m., there's only one physician again until 7 a.m. So from 8 p.m. till 10 a.m., there's only one physician in the department that's taking care of this volume of patients. And so the nurses will triage patients, and they triage them based on level of acuity. They ask certain questions for a reason. All the questions that the nurses ask you are to determine your level of acuity. And when they take your vital signs, they're looking for changes in your vital signs that could be concerning. And you're going to be seen based on your level of acuity, unfortunately, but it's the way that we take care of the sickest patients first, and it's what does the most good for the most amount of people. So, you know, it's unfortunate when you have to come and sit and wait, but something that I find interesting, Tom, is people from away who've lived in big cities where wait times for the emergency department can be 8 and 10 hours are always very thankful for their care here, because our wait times are rarely ever over 3 hours and typically under an hour.
That's a good point. I mean, people here, we're not used to sitting. It's like I grew up in New Jersey. I grew up a mile from New York City. You get into a traffic jam in New Jersey, you're in a traffic jam in New Jersey. I can remember driving down to my relative's house for Thanksgiving one year, and we were making great time until we got literally 20 miles from their house, and all of a sudden the interstate was backed all the way up. And man, that must be a really bad accident. So it took us almost as long to go that far as it took us to get there.
Yeah.
Find out the accident was on the other side of the road, and the reason it was slowing down is because everybody was stopping to look.
Rubbernecking.
Exactly right. So you get, you know, and the perspective here is you get into traffic jam, it lasts 5 minutes, and you complain.
Yeah, that's a great analogy. It's you just, if you've never experienced those long wait times, you don't know what it's like. So you think that an hour is a long time, but when you have people that are waiting 8 and 10 hours.
You must have some, I mean, I think if I was ever a doc, the emergency room might be the place to be, because you probably get challenged every day with something different.
The emergency department is a beautiful place to work. You see a broad variety of pathology. You see a broad age range of patients, and you see a broad spectrum of people with background and history, and you get to hear all the interesting stories too. I really like to take time with my patients, and I think anybody that's been my patient would tell you that you come in, you sit down, and I always make it a point to sit in the room if there's a stool. If not, I sit up on the counter. But I like to hear the story. I like to know about people. And I find that one of the most interesting parts of my job.
And it's got to be, having served this area, the people have a really interesting story. I mean, you yourself have an interesting story that if I were there, I'd be fascinated by by that and listen to that, because that also has an effect on your health and what you're about. And,
it does.
And your
it
family
does.
support and so forth.
And that's something that that healthcare has traditionally, up until recent years, neglected, is mental health. We've always kind of shunned it in this country, and it's gotten better, but it's still got a long ways to go. Mental health is extremely important, and where you stand in your mental health stature is important to the rest of your health, because the brain controls the rest of the body, and the brain can trick you into being sick when you may not actually be sick.
Or tell you you're okay when you're really not.
You're
really not okay, because we all go into denial. No, that can't be me. I think that thing that happened is not really me. So where are you living up here?
I live in Chesterville.
Good, Cheddarville.
About a quarter mile from the town office. With my wife and 3 fur children. I've got 2 German Shepherds and a Schnauzer.
All right.
You know, we enjoy the outdoors and everything that the outdoors has to offer. We grew up hunting and fishing, both of us, and that's something we still enjoy. Ski and snowboarding, those are both things we've done in West Virginia that we've continued up here. My wife recently got her permit to ride a motorcycle, so we went and bought her a motorcycle as well, and we've been riding this summer, and that's been really enjoyable. We love good food and good drink and good friends and the community that surrounds us. That we've never lived in a community like we have here.
This is a very special community.
It really is.
It really is. We accept people, most cases, who they are and what they are. We don't care.
Absolutely. I call it a libertarian mindset, and not to bring politics into it, but it's you do you, I'll do me. We'll meet in the middle and help each other where we can. Yep. And I love that about here.
I always tell the story about going to benefit dinners and somebody's there complaining that Tom's sick, and I'm not going to let him die from being sick. I'm going to help him, because at the end of the day, I want to be the one that takes him out. You know, but it's just a wonderful place and a wonderful community.
It is. I've lived a lot of places, and I've never lived anywhere like here.
Jodi, I want to thank you for coming on the show.
I want to thank you for having me, Tom.
Anytime.
It's been a great pleasure.
It's been a pleasure. And if I get a bulldozer, I'll call you.
Legitimately, if you need earthwork done, call me.
I actually know the guy who owns Taylor Construction, Adam Cody, and he has a couple. He's always looking for somebody to drive dump truck. So if you get in your spare time, I'll let him. I
can do that too. I'm always looking for side gigs.
Jodi, thanks for coming on. Great information. Great information about strokes. If you've got a concern and you think you got one, don't fool around.
Don't fool around.
Get it checked. I mean, I did when I got home. Christine basically said, "We're going to the hospital. We need to get this checked out." And later, I got out of bed one day, went too fast, and I was always leaning to the right, and I couldn't stop. I had a case of vertigo, but didn't know. Went to the hospital, did the same thing. I was clear. Yep. So I did it, but I did it because I know that if I treat it right away, it can make a huge difference. And I don't have many brain cells left, so I got to protect the ones I do have. Thanks for coming on, Jodi.
Thanks for having me.
Appreciate it. A lot of enthusiasm. Really appreciate that.
Thank you.
We'll see you next time on Talkin' Maine for the Bowtie Boy.